Hello there. I'm Linda Montgomery, the Program Director at the University of Colorado Family Medicine Residency. I want to present to you the slideshow that I normally would present to all applicants the morning when you would come to interview at our program. I think it contains some very valuable information that you should be able to consider as you think about where you want to do your training for the next 3 years. So first, a little bit about me. That is me right here. And here we are at a graduation ceremony for the residency. I came here to the University of Colorado 14 years ago to be a faculty member, and I was on a similar journey to the one you're taking today, trying to find that right place to become the best family physician I could be. And I found this place, and I've thrived and really enjoyed it. I've been here, as I've said, 14 years. I've been program director 9 of those years, and I've really loved creating a learning community that I hope that you will consider. So I've been a program director for a while, and I know that this is the question that you really are trying to get at when you go to visit programs. What really makes that program different than the 500 other programs in the country? And I think that this answer is how I would sum it up for our program. The very defining thing about us is that we are a cutting-edge urban safety net, Denver Health, combined with a vibrant university community, University of Colorado. And it creates a wonderful community in which to learn and practice medicine. So today, I'm going to be talking about a few things. I'll be talking about our 3 tracks embedded in some great teaching institutions with incredible faculty. I'm going to talk about our commitment to innovative family medicine education that leads us to have a uniquely designed curriculum that I really think makes residency educational, rigorous, and fulfilling, but even fun. I'm going to start with what is not the most important thing about our residency, but perhaps the most confusing thing, which is our 3 tracks. Our 3 tracks are our core program, which is the university track, and our Denver Health track. And then we also have our new rural training track. You all here this morning are interviewing for our core program, either one or both of our core tracks. Our rural training track has only been around a few years, where our core program has been around since the mid-1990s. Our rural training track, you should just be aware of, is a 2+1 program, meaning that the interns come to us and are like core interns in Denver, and then they're out to Fort Morgan, Colorado for the years 2 and 3 of their training. So our intern class is 13, and then those 2 go out to rural Fort Morgan, and the core program residents continue their training in Denver. So what are the core track differences? I'd like to say that there aren't many. The major one, and the major one you should consider, is that the continuity clinics are different. The continuity clinic at the university track is A.F. Williams. The continuity clinic at the Denver Health track is the Lowry Family Health Center. There are 2 other subtle differences. Out of 36 months of training, there's only 1 rotation that's different between the track. In the university, everyone does rural for 1 month. At Denver Health, everyone does refugee care for 1 month. And then, out of the 36 months of training, sometimes I have 2 training sites. So for instance, NICU, newborn, inpatient pediatrics. I have sites both at University, Children's, and Denver Health. If you're on the university track, I will put you slightly more at University and Children's, and in Denver Health, I'll put you slightly more at Denver Health. This is a way to get more continuity with your patient population. But again, main difference is the clinics. The similarities are much greater than the differences. We have the same leadership, faculty, didactics, curriculum, and rotations. And everyone serves on our family medicine inpatient services at University and Denver Health. So we have inpatient services at both hospitals, and no matter what track you're in, you will serve on those services as well. But the continuity clinics are different, and that means a lot in family medicine. In family medicine, you have to see 1,650 patients at your continuity clinic, and that's a lot of time. If we're doing it right, you are getting a lot of your education at your continuity site. So choosing that right continuity site is very important. First, we'll talk about the university's continuity site, A.F. Williams Family Medicine, named for A.F. Williams, who was a very storied family medicine doc who, besides being a good family doctor, also made some good money and left it to a foundation, and they built this clinic for us. So that's why it's named A.F. Williams Family Medicine. You can think of it as the largest family medicine clinic in the University of Colorado system and where the residents are. It is the outpatient practice for 20 residents, so 2 rural track interns plus 6 university residents per year, and then also an equal number of attending physicians. So about 40 physicians work here in any given month. We see about 40,000 visits per year at this clinic. You can see the payer mix there. So about half Medicaid, Medicare, and half commercial. Interesting things about the patient population here. We are the primary care choice for many of University of Colorado's attendings, fellows, residents, and medical professionals. So about a third of our commercial payers or commercially paid patients are from the university. We also have the highest patient complexity score and one of the lowest readmission rates among all CU primary care clinics. And I really think it's because we have our own inpatient service, and most of us work both on the inpatient service and in the clinic, and therefore render very high level care for complex patients. University faculty. This is one of my main jobs, is to make sure our patients and our residents have the very finest faculty to take care of them and to teach them. You will see a broad range of people here of all different ages. They have expertise, fellowships in palliative, sports, practice transformation, C-section, OB, advanced training, a wonderful mix of some of the most talented academic family physicians in the country. A.F. Williams is known as an interdisciplinary hotbed. This was really the reason that I chose this as my clinical site. Even 14 years ago, A.F. Williams was known as a clinical site that had deep interdisciplinary roots. Many clinics have psychologists and pharmacists, so you'll find that in a lot of places you go to. But what you should know about this clinic is that we have training programs here. So embedded within A.F. Williams is a psychology residency and a pharmacology residency. And so you will have people who are committed to primary care, pharmacy, and psychology who are training right next to you, seeing your patients with you, learning with and from you, and teaching you as well. We also have psychiatry, telepsychiatry, and those residents rotate through and see our patients with us as well. So this is a lovely thing. I can't underline it enough how wonderful this particularly is. Lowry Family Health Center is our Denver Health Continuity Clinic. It is the outpatient practice for 15 residents. It is also has many attending physicians as well. There are, the thing to really know about this clinic is its international flavor. It has 30% Spanish speaking, 50% non-English, non-Spanish speaking. This is one of the most globally oriented primary care sites you will ever practice at. One of the reasons that this is because it is the site of the Denver Health Refugee Clinic. So those refugees tend to stay here for their care. They also see about 40,000 visits per year. You can see the different payer mix here. It is a majority Medicaid population with a smattering of other payers as well. The Denver Health faculty, some of the most qualified and committed faculty involved in FQHC care in the whole country, led by Lucy Loomis, who is really sort of one of the mothers of the FQHC movement. They have deep FQHC experience, a lot of expertise, and a lot of commitment and compassion around care of the underserved. Lowry also has rich team-based care with integrated behavioral health, psychiatry, addiction counselors, pharmacy, family planning, patient navigation team, social work. The twist here is that they very much have expertise in how to give care to an international and refugee population. So both have interdisciplinary teaching and learning, and both clinics have addiction and gender affirming care. And both have great staffs. So how could you ever decide? It is a hard decision. They are incredibly great continuity clinics, but they are different. If I get one question at the end of recruitment in February when people are putting together their lists, it is this: which track should I rank above the other? And I always remind them of this cheat sheet that I show. Lowry is great for exposure to FQHC-based care within a nationally renowned safety net system. It is great for immigrant and refugee care, and is particularly good for LGBTQ plus care. It is the director of the Denver Health's LGBTQ Center for Excellence, is one of our major faculty members at Lowry. A.F. Williams, the university's continuity clinic, is great for exposure to innovative primary care redesign. For the last 10 years, this has been known as one of the most innovative primary care clinics in a residency practice. It's also known for wonderful academic medicine mentoring. The 10 core faculty who call this their continuity clinic where they practice are all committed to academic mentoring. And it's a great place if you want to get up close and personal with that kind of practice. It's also wonderful for sports medicine exposure. I've put here an article at the bottom here called Practice Transformation under the University of Colorado's Primary Care Redesign Model. I encourage you to Google practice transformation in University of Colorado, especially among our residency. And if this is interesting to you, and explore the rich literature that has come out of our being on the cutting edge of innovative primary care redesign. To explore these two clinics further, I really encourage you to watch the video that is done by our medical director and our associate program director in the two clinics to get more information about the clinics. Now we're going to move on to our quality teaching institutions. We have three main hospitals. The first, University of Colorado Hospital. It is the home of our family medicine service, and everyone does their second-year OB rotation here. And some do internal medicine, emergency room, newborn, ICU, and more rotations. Denver Health, we're all due our adult family medicine service, our first-year OB rotation, our first-year surgery rotation, which is our only surgery rotation, and our third-year geriatrics rotation. And we're some do internal medicine, emergency medicine, pediatrics, newborn, ICU, and more. Children's Hospital Colorado, where some do their inpatient and outpatient pediatrics rotations, pediatric emergency medicine, and pediatric electives. Where are these things? You might be wondering, are they all over the place? They're not. Here's a map of Denver. Our two continuity clinics are A.F. Williams, right here, and then 2 miles, about 2 miles south, are Lowry Family Health Center. And then about 2 miles in that direction as well, you're going to find on the Anschutz Medical Campus our University of Colorado Hospital and our Children's Hospital. And then several miles further down toward downtown, the mountains are out here, but down toward downtown Denver is Denver Health. On any given day, you wouldn't really be having to go to more than 2 of these spots. Sometimes you have to be at an inpatient service and then in a clinic in the afternoon. But generally, we try to minimize your travel across town. One thing I'd like to mention is that we are embedded in a very cool department of family medicine. These are 3 of my grads who are all faculty members in the Department of Family Medicine. I like to use them to show you the vibrant spirit of our Department of Family Medicine. When I was looking at programs, when I was at your stage, I don't think that I was thinking about the department that the residency is embedded in, but I think it's important for us because we have a very good relationship with our Department of Family Medicine. The University of Colorado Department of Family Medicine is really known for its innovation. I encourage you not only to look at our residency website, but also the Department of Family Medicine website. It's one of the biggest and the first departments of family medicine, and being big and old is not always good, but in family medicine it actually works rather well. We hold a position at the table at the University of Colorado that I think is well deserved and gives us some opportunities within the university. The department is known for jumping into many national demonstration projects and educational and clinical redesign. They do lots of research at the Department of Family Medicine. It has a very innovative and fresh spirit. And so I encourage you to explore that spirit by looking at the department's online magazine called Precipice. If you just put Precipice University of Colorado, you will see that our department likes to ask hard questions and then try to answer them by getting a lot of voices involved. So please explore Precipice. I think you'll see that the Department of Family Medicine here at the University of Colorado is worth getting to know. We have many national leaders in family medicine, in research, and in FQHCs, and in the integration of mental health into primary care and other very laudable projects. So these people are accessible, very accessible to residents, and many of them precept on our inpatient and outpatient services. I encourage you to look at the people you might encounter at the Department of Family Medicine. To get to that place of being a national leader, you have to start somewhere. So I really encourage my residents to carve out the time to be involved in local, regional, and national activities. And you can see many of the organizations that our residents have gotten involved with and provide leadership for. We have many residents who we nominate for national awards and scholarships. I really do try to work with each resident to carve out the time and the finances so that they can actually participate in these type of activities. And then we also are very well known for scholarship. We have faculty and residents who really lead the way in getting out there and showing their scholarship nationally. I like to support residents with time and finances as available to go out to national meetings and present their posters, present their podium presentations, to really be involved in the scholarship that pushes family medicine forward. I next like to talk about our commitment to innovative family medicine curriculum. So I said we had a commitment to it. What does it look like to try to be on the frontier of family medicine residency education? And we have been involved in a national demonstration project over the years called P4. which is a national demonstration project, which really tried to ask and answer the question of what made a 21st century family physician. And these are the elements that we came up with. I'm going to explain the elements in more detail. A major piece of our curriculum that's longitudinal throughout the 3 years of training is around practice transformation, how to be a high-functioning primary care clinic. And we have created a longitudinal curriculum that has pieces in all 3 years in leadership, practice transformation, and QI. We have dedicated months in our 2nd year and 3rd year around practice transformation to really put into practice what you are learning around these important concepts. We have been able to train and to attract some big national leaders in practice transformation who both teach and create this curriculum. We also have a big commitment to community engagement. My background before going into medicine was in community health, and I really hold dear the thought that family medicines and the conviction that family physicians really need to understand their communities and know how to advocate and engage with their communities. I was able to hire Heather Bleacher and Carrie Mader, who are our leaders of this curriculum. And here's a picture of Heather out with one of our graduates presenting on kind of a hot spotters project that they did. They've created a wonderful curriculum called, I will go back for a minute, Population Health, Advocacy, and Community Engagement, with these very laudable objectives that when you graduate, you should be able to identify and address non-medical factors that influence the health of patients and populations, that you will be able to partner with community groups and public health entities to promote wellness of individuals and communities, and that you really should be able to evaluate the influence of public policy on health and advocate for positive change. We have a very nice longitudinal curriculum that tries to push all of our trainees to obtain these skills using workshops, community work, neighborhood immersion. We also feel that behavioral health integration is part of the recipe of being a fabulous family physician. So we have psychologists and psychiatrists at both clinics. You saw the slides with all of the dripping with all of the behavioral health professionals at both of our clinics. But if this doesn't come down to your training here, it's all for naught. Luckily, we really involve you in the behavioral health in the clinics. I am well resourced by my department and able to hire a full-time director of behavioral health education, Alex Reed, who has dedicated his life to teaching how to really have high-functioning integrated behavioral health in residency clinics. And he plans our didactics, our longitudinal curriculum, and electives. We also have buprenorphine training for all the residents within their first year. Another element in that recipe of how to be a high-functioning and happy family physician is around physician wellness. So we have been on the cutting edge of creating physician wellness curriculum. This is a very important thing now to our accrediting body, the ACGME, and I am happy about that. But we have been doing this for about 11 years, having dedicated faculty and a longitudinal curriculum, both in our inpatient and outpatient setting, that really tries to hit the developmental stage that is residency. That's different than being a med student, different than being an attending physician, really trying to capitalize on giving you the core concepts and practices that will make you a sustained physician over time. Another thing that we have been on the cutting edge of is innovative curriculum structure. We have been moving around things in our curriculum, really trying to capitalize on how do you take advantage of good training over time that does not burn people out during the 3 years of rigorous family medicine training. I'm going to talk mostly about our first year innovations because those are the ones that have been most revolutionary. In our first year of training, we have 3 Chautauquas, which are 3 intentional learning months that I will show you more about in a second. We originally called them intentional learning months, but that didn't quite capture what we wanted out of those months. So we held a contest, and Chautauqua came to mind, which is, it was a movement in the late 1800s to when people weren't going to college, and they would get together over the course of several weeks and learn in kind of a non-religious camp revival way. And they would learn about, with and from each other, about math and music and science and medicine and literature and poetry and things like that. And we thought that that really embodied the rich learning community that we wanted to create with our intentional learning months. So we call them Chautauquas. You can think about them as 3 intentional learning months that prepare you for the rotations that follow. They occur in July, November, and June. They prepare you for a group of rotations that are about to happen. So you can see a theme here. After Chautauqua 1, almost everyone in some combination does medicine, surgery, and emergency medicine. And then after Chautauqua, and then they'll do Chautauqua 2. And then the theme here is more around pediatric and obstetrics rotations. During that time, people also rotate on our own family medicine services at Denver Health and University in some order. And then the third Chautauqua prepares them for their 2nd year of residency. What's in a Chautauqua? A Chautauqua has a theme. As you can see, med, surg, OB, peds, ICU, or clinic. In it, it has lots of medical knowledge review, lots of applicable procedure workshops, lots of applicable advanced life support classes. It also has clinic and outpatient skill building, such as panel management and EPIC skills. And it really gives us a time to work on those things that I brought up to you, that basket of things that we need some longitudinal time to explore, such as practice innovation, community engagement, physician wellness, and information mastery. We did Chautauquas because we really felt that intern year was both the worst and the best of times. You learn a lot in your intern year, but you can learn it in all different sort of unplanned ways that can cause stress. And the Chautauquas have provided us a way to prepare you for the rotations that will follow, and also to give you time in longitudinal projects and experiences that we really think you need to be the most fulfilled physician and intern that we can create. The Chautauquas also have provided a lovely time for us to be together and bond together. They're all taught by mostly family physicians. They're non-call months. So it does, although we make them as rigorous as possible, some of that rigor is around getting to know one another and spending time together. So the Chautauquas have also served a beautiful social reason as well. Our development never stops. So we're continue to try to develop cutting edge curricula for our residency. And as we speak, we have and are creating curricula in these important areas of addiction and MAT, LGBTQ care, health policy and advocacy, diversity, equity, inclusion, and anti-racism, and leadership. We have leadership already in the curriculum, but we are creating a concentration so people can do more work in leadership if they would like. So this is not to show you that, you know, we're politically correct or anything like that. It's really to show you that we are continuously trying to ask and answer the question of how to make you the very best, most useful physician for the communities that you serve, as well as the most fulfilled physician you can be. I want you to know a few other things before we end. We have excellent MSK training. We have a sports medicine fellowship embedded within our department, and the core faculty of that fellowship are some of our core faculty as well. We have a wonderful MSK1 rotation in Denver, and then we have a really excellent MSK2 rotation at our clinic at the base of Winter Park, so lots of trauma care there. And we have amazing support and research for those seeking fellowships in sports medicine. We also have excellent preparation for academic careers. As I said, we have great mentoring around being an academic doctor, but we have some content in didactics. We have students with us, so you will get a chance to teach in our clinics and on our services. You can teach at our student-run free clinic, which is the leader of which is one of our core family physicians. We have a dedicated elective in residence as educators. It's like a mini academic fellowship. So if academics is something that you are even thinking about, this is a great place to explore that. Maternity care, we have both basic and advanced. So everyone does 1 month at Denver Health, everyone does 1 month at university. And then, and the RTT, they actually do a month at Fort Morgan. But in the core program, everyone does 1 month at Denver Health, 1 month at university. They are good rotations that give you some wonderful foundation in maternity care, but many of our folks want more. So we have our advanced maternity care concentration. Please, I encourage you to go to our website and look at the information about our advanced maternity care concentration. It's just an excellent way to do some extra work to make sure that you get ready for maternity care if you want to do that, like about half of our graduates. So how do we compare nationally? I do keep statistics on my classes, the ones that I've graduated here. So the classes of 2010 to 2020, 48% of them are doing prenatal work and 26% perform vaginal deliveries out of those 10 classes. And that compares very favorably to national statistics. AFP says that that is 19 and 17% from their data gathering. Another thing to know about us is that we have a lot of neat evening working groups. 3 that are very active: our health policy and advocacy group, our refugee health group, and our social justice group. I provide just pizza money, and then they do wonderful work in these areas, and it's people from both the faculty and the residents and the fellows attend these evening working groups. One thing that I think is important for you to know is that we really do have a commitment to diversity, inclusion, equity, and anti-racism. We have more of this about this on our website, and I encourage you to watch our video about this. We are taking some humble but tangible steps to be better at this. We have undertaken a holistic review process for all of our, when we are doing your review as a medical student, when we are hiring faculty, when we're hiring staff, we have adopted the AAMC's holistic review algorithms, and we are very committed to trying to make sure that we are looking at the whole candidate. We have, as I said, our social justice working group. We also have a social justice book club that meets regularly. We provide implicit bias training and actually require it for our faculty and our residents. We signed a national anti-racist medical education pledge that is mostly signed by family medicine programs across the country. And our department is aligned with us in this commitment, and they appointed one of our core faculty members, Cleveland Pickett, to be the new vice chair for diversity, equity, and inclusion. So we continue to work on this, but I did want you to know that it is part of our core values to be committed to diversity. You might say, well, Dr. M, what are your outcomes here from 10 years of trying to make the very best family physician you can find? Well, I do think that we are making residents with new skills and creating and leading transformed practices. And I think more than ever, we are attracting people here, training them up, and they're able to go out and create very interesting careers. So a few statistics. Of our 106 grads from 2010 to 2020, 45 did or are doing fellowships. You can see the major ones represented are sports and OB women's health, with or without C-section training. So you can see those are definitely the leaders. And then we also have quite a bit of interest in palliative medicine, policy, and global health. And then you can see others. We have lots of ability to help you get into fellowships, to find fellowship opportunities, if that's what you want. As you can see, it's less than 50%, but we do support you if being fellowship trained is something that you are interested in. We'll help you find that right next spot. And then more of our outcomes data. So you can see it here. A lot of people say, well, how many people come from Colorado? It's small. It's usually fewer than one out of a class. But out of those classes, 68% are still in Colorado or have come back. About 29% are in private practice. 26% are in some form of a community health center. 13% are rural, and we have quite a few people who are either a core faculty member or teach in a department of family medicine, 31%. I'd like to end on a different note than you've probably seen program directors end, which is around what we value in this residency. I'm talking from my heart. I've not taken a survey of the residency and the residents, but I do think that as the leader of this residency, I can speak about what I see represented in the values of the residency. I think that at its heart, we have a sincere interest in doctoring. We have very big intentions to make you the very best clinician that you can be, the very best physician in all of its flavors that you can be. We want to make sure that you have the skills that you need to be that wonderful family physician. Beyond the bugs and drugs, which you will definitely get at our great teaching institutions, beyond that training in bugs and drugs and the nuts and bolts of medicine is that bigger basket that I showed you to make you a satisfied and happy and fulfilled physician who is in the workforce for a long time. Then to make that kind of doctor, we have to value inquiry and innovation, collaboration and teamwork, and diversity and inclusion. And we have to actually value that we have a responsibility beyond our own program, beyond the walls of our own clinics, to improve the care delivered in our communities, in our state, and really in the world. So I want to thank you so much for sharing this time with me. Please feel free to reach me through my email address with any questions, concerns that might come up after viewing this presentation. And I really, really appreciate your time here with me today.